Welcome back to Hematology. Today we are going to go over our coagulation case studies number 1 and our coag disorders worksheet. Hopefully you have had the opportunity to complete both of those assignments, but this PowerPoint will be a review of those with explanation and an answer key. So please try to answer these questions independently prior to watching this PowerPoint. Let's begin with case study 1.1. A 50-year-old male was seen in the ER complaining of chest pain. He had been transferred from a small rural hospital near his home. The ER nurse did not know if the patient was on anticoagulants. First, let's take a look at his lab results. We have some coagulation testing that we performed, and we also have a platelet count, presumably from his CBC. The lab results are as follows. Our platelet count is 194, PT is 21.1 seconds, PTT 81 seconds, and fibrinogen is 220 milligrams per deciliter. What test would be performed next? Okay, so let's first take a look and see and ask, well, we're going to ask ourselves, do we see any abnormal results? Well, PT looks all right. PTT is prolonged. Fibrinogen looks all right, and our platelet looks all right. So really the only thing there in that result is a prolongated PTT. So what test would we perform next? Well, let's think about that. And based on the results of this test, what follow-up should be done? Well, we know it's likely not part of the extrinsic pathway. We know we have fibrinogen. We know we have enough platelets, but what could affect fibrinogen activation and platelets and could cause prolongation in the PTT? I think if we really think about it, we know that thrombin can affect all of those things. So maybe we would want to perform a thrombin time perhaps. Based on the results of this test, what follow-up should be done? Okay, so while you think about that, I'm going to pause and then we'll move on. All right, the very first thing we're going to want to look at, again, are the abnormal labs. And then we need to ask ourselves a question, what could cause this lab to be abnormal? So there are a couple of things that can cause a prolongated PTT. Let's think about it. Anticoagulation therapy, such as heparin or a direct thrombin inhibitor, could cause a prolongation in PTT. And again, it does say that she doesn't know if the patient is on anticoagulants, but he could be, especially if he has a history of cardiac illness or cardiac disease. Let's see what else. A factor deficiency could cause a PTT as well, prolongated PTT. And the other thing that would cause a prolongated PTT are inhibitors. Whether it's a factor inhibitor or a non-specific inhibitor, both of those can cause prolongations of the PTT. So again, 3 things can cause a PTT prolongation: factor deficiency, anticoagulant therapy or medication, and inhibitors. So we know that thrombin is an important part of primary, secondary, and fibrinolysis hemostasis. If we perform a thrombin time and it is greater than 60 seconds, that's an indicator that this patient is indeed on heparin, and that is what's causing the prolongation of the PTT. At that point, we don't need to do any further workup. If we wanted to, we could run a test called an anti-10A, which is a test we haven't really discussed yet. We're going to get to that, but that will directly measure heparin. If the thrombin time is normal, however, we are going to need to do what is called a PTT mixing study. If the mix does not correct, this indicates an inhibitor, such as in a lupus anticoagulant or an antiphospholipid inhibitor, and if it corrects, a factor deficiency could be the cause, and then we would result to doing our factor assays to determine which factor is deficient. Now, I know this one was a bit tricky because we don't have all the pieces of the puzzle yet. I just wanted to demonstrate how to think and process that. We will get more into our mixing studies and our methodologies here in a little bit. So answer the questions as much as you can. Again, if you have any questions, please reach out to me. But come back and revisit these case studies if there are some questions that you haven't been able to answer once we get further along in terms of our testing methodologies and some of our coagulopathies. You might have some more pieces of the puzzle, but at the end of it all, you'll have all the information at hand where you can come and easily answer these case studies. Don't be afraid to skip it and come back to it if you need. Okay, case study 1.2 or 1-2, a 27-year-old female was admitted for evaluation of a lifelong tendency to ooze from wounds. That sounds unpleasant. Physical examination revealed several large bruises. She was not currently taking any medications, and there was a family history of easy bruising and abnormal bleeding from superficial wounds. This patient's PT was 11.7, PTT was 30, fibrinogen is 250, and her platelet count is 280. So everything for the most part looks pretty good. I don't see really any abnormal results there. So let's take a minute and think, what test should be performed next? Okay, I'm going to let you think about it. After you've completed and answered the questions to the best of your ability, we can talk about it. Case study 1-2. Again, this 27-year-old female was admitted for evaluation. Now there are a couple of clues right away of what we may be looking at in the patient history and her clinical indications. So lifelong tendency to ooze from wounds, so that means probably poor healing. Physical examination revealed large bruises, and she was currently not taking any medications. Also, there was a family history of easy bruising and abnormal bleeding from superficial wounds. This is not doesn't appear to be a hemorrhagic, something that would be a hemorrhagic problem, just more slow healing, oozing. Something's going wrong toward the end of coagulation, and I would suspect that it might be a factor 13 deficiency. The reason for that is both her PT and PTT are normal. She has fibrinogen. She has a normal platelet count, so nothing that appears to be out of whack here. And again, remember, we do not measure the factor 13 by the PT or the PTT. So the best thing that we could perhaps do is do a clot solubility in that 5 molar urea, the same test that we did in student lab, or if we haven't gotten to that at this point when you're listening, it is the same test laboratory activity that we have planned for coagulation. Now remember, what percent of activity is needed for normal clot stability? That is going to be 1 to 2%. Make sure that if you are looking for the answers or you're looking for an explanation to these case studies, go back to your PowerPoint presentation and take a look to see that will aid you in answering these questions. And then of course the probable diagnosis would be our factor 13 deficiency. What is the treatment of choice? FFP or cryoprecipitate. Let's take a look at case study 1-3. A 5-year-old boy injured at play presents with marked knee swelling and a soft tissue hematoma of the right thigh. The child has no current medical problems, but his parents describe a bleeding tendency since birth, including cephalohematoma and other soft tissue hemorrhages. Although the patient has a hemarthrosis of his knee at this time, this is the first instance of joint bleeding. He has no siblings, and there is no familial bleeding history. All right, so the first thing we're going to do is look at his coagulation results. It looks like they just ran a PT, a PTT, and a platelet count. So ask yourself, which of these lab results do I see that could point me in the right direction? Well, right away, I noticed that the PT is prolonged, but the platelet count is normal as well as the PTT. So those are both normal. It is the PT that's prolonged. That's going to give you a very good indication right away that this is something going to be associated with the extrinsic pathway. The reason we know it's the extrinsic pathway only is because that PTT is normal. If it were something in the common pathway, we would have prolongation of both the PT and the PTT. So go ahead and try to think about the things that could be deficient or the deficiencies that match the patient's clinical presentation or the clinical indications, as well as those things that are associated with the extrinsic pathway. Take a minute, try to work through this problem, and I will see you on the next slide with an answer and an explanation. Now that you've had a few minutes to kind of evaluate this case study and think it through, I hope that you came to the determination that this congenital bleeding disorder is a factor VII deficiency. So we suspect it's factor VII deficiency because, number one, it's the PT that's prolonged and everything else is normal. He has had a bleeding tendency since birth, and we know very well that we can sometimes see joint bleeding or hemarthrosis in factor deficiencies of 7, 8, and 9. So I hope that you were able to come to that determination. Now, if the congenital nature of this case was not clear, what are the acquired causes of this disorder? Well, there are a few acquired causes of vitamin 7 deficiency. We know that that factor 7 is vitamin K dependent. So vitamin K deficiency could cause an acquired depletion of factor 7. Liver disease, because again, factor 7 is produced in the liver. GI disease, so if we have diseased GI tract, our normal flora may not be present, or may be in the wrong ratio, or maybe we aren't able to digest nutrients the way that we normally would if we were a healthy individual. Coumadin use or overdose. So again, anticoagulant therapy. There could be an inhibitor or an antibody against factor 7. And of course, prolonged antibiotic use. And that is because the antibiotics kill not only pathogenic bacteria, but also our normal gut flora, which is responsible for helping to produce that vitamin K. What is the biologic property of the pertinent factor? Is it important in therapeutic decisions? Well, yes, definitely is. If we have a factor deficiency like 7, because factor 7 has the shortest half-life of all of the factors, and again, remember it's only about 4 to 6 hours, only that PT is abnormal, and therapy would need to be more frequent to account for the short half-life. So all of those things have to come into play to make it therapeutic decisions. Let's move on to case study 1-4. A 10-year-old boy injured in a softball game presents with a left leg hemarthrosis and cathechemosis. He has had no previous surgeries, but after an earlier injury, he required a blood transfusion for prolonged bleeding. His parents were told that he had a factor VIII deficiency. He has never received other blood products and has not had spontaneous bleeding. There is no family history of bleeding. With a negative family history, could this be hemophilia? Well, let's take a look at these. I'm going to give you some time to work on this case study 1-4. And when you have completed it, come on back and we'll talk about it and have an explanation. Welcome back. Case study 1-4. A 10-year-old boy injured in a softball game presents with a leg hemarthrosis and calf ecchymosis. He has no previous surgeries, but after an earlier injury, he required a blood transfusion for prolonged bleeding. So this is going to be a sign. Prolonged bleeding is not normal. His parents were told that he had a factor VIII deficiency. So they've already done testing for factor VIII deficiency and determined that he does indeed have a factor VIII deficiency. He has never received any other blood products and has not had a spontaneous bleeding. And there's no family history. So factor VIII deficiency, also called hemophilia A, could this patient have hemophilia with a negative family history? And the answer to that is yes, they could, because all inherited disorders, for the most part, begin with some type of a gene mutation, and there's always the first person in the family to have that gene mutation. So possibly this patient has a spontaneous mutation, which led to a factor VIII deficiency, and now he will continue to pass on this trait to his offspring. The patient was given factor VIII concentrate in the ER, but continued to have ankle swelling. How can this be explained and what tests should be done? Okay, so they gave him some recombinant concentrate of factor VIII, but unfortunately that's not solving the problem. So let's think about this. We've given him back the component that he's missing. It's not working. So there must be something inhibiting that from aiding with the coagulation. So this patient could have had a factor VIII inhibitor, and that's going to be binding up that factor VIII concentrate. So in this case, we should do a factor VIII inhibitor assay just to make sure. Based on this patient's history and estimated level of deficient factor, I would say this patient probably has mild to moderate, maybe about 5, maybe 10% activity. And the reason for that is he doesn't have an extensive history of serious hemorrhage, but he does have some bleeding in his history. If this patient were severely deficient, we would see hemorrhagic activity maybe, or even repeated blood transfusions. And it says here he's only ever had 1 blood transfusion. If the patient developed an inhibitor, what possible treatments could we consider? Well, there's a couple of different things that we could do with inhibitors. We could treat with a different concentrate like Novo-7. Remember we talked about that, where we can bypass that intrinsic pathway step and kind of detour around it by utilizing that Novo-7. We might be able to use plasmapheresis to kind of evacuate that inhibitor that's in circulation. And there's actually a newer medication. To be honest with you, I don't know too much about it, except for the fact that it's a factor VIII inhibitor bypassing drug, so it has bypassing activity. And I assume it would probably work similar to Novo-7, but honestly, um, I'm not thoroughly familiar with it. I am going to look into it though, and maybe at a later time I'll have more information for you about that. Case study 1.5. A 74-year-old man is recovering from cholecystectomy, which means he had his gallbladder removed. He developed a postoperative wound infection, received antibiotics, and then 3 days later began to bleed from the surgical wound. His postoperative coagulation results were normal, but now the PT is 31.5 and the PTT is 49. The platelet count, however, is normal. Okay, so it looks like he's got a prolonged PT and a prolonged PTT. Interesting though that initially he had normal coagulation, and then after 3 days on antibiotic, he began to have a prolongation. So, what is the likely diagnosis and what would be the appropriate treatment? Okay, I'm going to let you think about that. And when we come back on the next slide, we will talk about it. Good luck. All right, let's take a look at case study 1.1-5. So the 74-year-old man had his gallbladder removed. He developed postoperative infection and was given antibiotics. 3 days later, he began to bleed from the surgical wound. His preoperative coagulation results were normal, but now his PT and his PTT are both prolonged, but he still has a normal platelet count. What is the most likely diagnosis? Well, we know that antibiotic therapy can cause a destruction of our normal gut flora, and those normal gut flora are responsible for production of vitamin K. If we are deficient in our normal gut flora, if it's dwindling due to that antibiotic use, we will also become deficient in vitamin K. What would the appropriate treatment be? Well, obviously FFP, because we have more than one vitamin K dependent factor, so it isn't just one factor, so we would need that FFP, which has multiple factors in it. And we may also supplement with a vitamin K shot or a few, and over time that would provide the body with enough vitamin K to continue making those or producing those vitamin K dependent coag factors during the remainder of his course of antibiotics. Moving on to case study 1.1-6. A 12-year-old girl previously diagnosed with systemic lupus erythematosus, or SLE, is hospitalized with fever, epistaxis, and hematuria. Let's take a look at her lab results. So she does have a normal PT of 12 seconds, a prolonged PTT of 79 seconds, and then they also performed a PTT mixing study. Let's see here. The normal pooled plasma was a PTT of 30 seconds. And when they did a one-to-one mix of patient and pooled plasma, the result is 61. Now the question you want to ask yourself is, are we adding normal pooled plasma to the patient sample, and are we able to get a normal result when mixing it? Because the idea of adding pooled normal plasma to a patient who's deficient is that the factors in the normal pooled plasma should replace what is deficient in the patient sample. And we call that, if that does occur, if we have a prolongation initially and then in the mixing study it corrects that prolongation to like a more normal result, we call that a correction. But if we don't see a normal result after the mixed study, we would call that a non-correction. And a non-correction would not be indicative of a factor deficiency, but rather some type of inhibitor. So I'll let you think about that, and we will go over the explanation when we come back. Case study 1.1-6. So we're back to looking at our 12-year-old girl who had previously been diagnosed with SLE and is hospitalized with fever, epistaxis, and hematuria. We had a 79-second PTT with the initial patient sample. The normal pooled plasma is 30 seconds, and the mixing study for the PTT, the one-to-one mix, is 61 seconds, which is still prolonged. Now let's take a look here. It's true it's a little bit shorter than the PTT that was originally run, but it's not clinically significant in terms of the difference. So it is still considered to be prolonged. And the normal pool plasma was 30 seconds, so I would call that a non-correction. 61 is not a normal value. So again, what are the three causes? What are the three things that could cause a prolonged PTT? Anticoagulant therapy, a factor deficiency, and an inhibitor. We know this is probably not indicative of a factor deficiency because the addition of that pooled normal plasma did not replace or correct the PTT. If this had been a deficiency and we added normal pooled plasma that have all of our coag factors present, it would have replaced what was missing, and then you would have a normal PTT, and that is not what happened. So I think we can rule out factor deficiency. It doesn't say anything about this patient being on anticoagulants, but I can tell you that when we have we do a PTT mixing study and we are not able to achieve a correction, that it's highly indicative of some type of an inhibitor. And in this case, I would suspect it's a lupus anticoagulant, or sometimes called an antiphospholipid syndrome, because the patient does have a history of systemic lupus, and this is a very common inhibitor that comes along with this diagnosis. And this is considered a non-specific inhibitor, so it is not specific to any one factor, but it affects multiple factors. Other tests that we might perform that could be useful is, first of all, after the mixing study, we might do a DRVVT test and a hex phase test, and we'll talk more about them moving forward once we get to our methodologies. What paradoxical problems can these patients have? Well, interestingly enough, um, although the PTT is prolonged, which might make you think that they have a bleeding issue, they actually have an increased risk of thrombosis. And the reason for that is because if you look at this antiphospholipid syndrome, the name right here, our prolongation on the PTT that we do in vitro actually comes from an interaction of this inhibitor with the phospholipids that we use during testing on our instrument. So this is not a true representation of what's happening in the body, but it is an indicator of this nonspecific inhibitor. There are a few other situations that can cause this phenomenon. We can have certain drug therapies, infections, malignancies. In what situations might these patients have a bleeding risk? Well, thrombocytopenia, platelet dysfunction, and other deficiencies and disorders. So these would be things that could cause bleeding risk if it was in correlation with this lupus anticoagulant. Because remember, some people really hit the jackpot and are very unlucky, and they have multiple issues coinciding one with another. Even though they may be independent issues, they got a double whammy of coagulation fun. Case study 1-7. A 52-year-old man is admitted for evaluation of jaundice and liver disease. The patient admits to heavy alcohol use. Now, I just want to make one point about patient care, especially direct patient care. Although there will be a lot of MLS or lab scientists who never have to do direct patient care in terms of face-to-face care, but many, many, many of you will have to. And I just want to, point out that our job is not to judge patients. Our job is to aid in, collecting and analyzing labs for physicians to come to either a better diagnosis or a better treatment plan for the patient. So I think that sometimes when we work in healthcare for a long time, we kind of become a little bit seasoned, so to speak. Maybe we show less empathy for patients who do things that we don't understand. But I just really want to make a point that the reason we don't judge people as they come to us for help is because we don't want them to withhold information that could be pertinent to their treatment or their diagnosis. So keep that in mind. We never want to make anyone feel bad. I mean, I think it's unfortunate that, some patients have physical damage due to maybe life choices, but that's their decision, and we are here to help them. Okay, now I'll get off my soapbox. I just always, feel like that's an important thing to reiterate to incoming lab scientists who may have direct patient care experiences. Okay, so what is the likely cause of the coagulopathy, and why is the patient thrombocytopenic? How is the factor VIII level affected in liver disease? Okay, so all of those are great questions. See if you can find the answer to them, determine what's going on with this patient, and we'll come back and talk about it. Okay, let's tackle this one. So here we have a 52-year-old man admitted for jaundice and liver disease, and the patient admits to heavy alcohol use. Coagulopathies or coagulation issues very, very often present with people who have liver disease or liver failure. And the reason for that is that liver disease leads to a diminished synthesis of coag factors that are produced there in the liver. It also leads to thrombocytopenia. Why? Because alcohol use can suppress hematopoiesis, as can the concurrent folate deficiency. So if you guys think back to our normocytic normochromic deficiency, alcohol use was one of the causes, and that can either be due to suppressed hematopoiesis, or alcohol can also be associated with some of our macrocytic anemias. So think way back to our red blood cell unit. Portal hypertension from liver disease can lead to platelets being destroyed in the spleen. And again, the liver aids in platelet production. It's not the primary source of platelet production. Obviously, that would be the bone marrow. But if you think about the fact that the liver does play a small role in hematopoiesis, we would definitely recall that. How is the factor VIII level affected by the disease? Well, let's think about factor VIII. What do we know about factor VIII? We know that it is produced, or that it's found not just in circulation, but also it is produced in endothelial cells at the site of injury, if it were there, or in those platelet granules, right? So if a patient has liver disease, it could be decreased, but again, our body's very good at compensating for low levels or loss of something. And this could be due to extra synthesis for megakaryocytes and endothelial cells. So it may be that our body's trying to compensate, and so liver can't do his part, and so our endothelial cells and megakaryocytes start compensating for that. All right, I hope that makes sense. Any questions, please feel free to contact me. Let's move on to case study 1-8. Okay, a 67-year-old man has long-term Coumadin therapy for recurrent thrombosis. He presents in the ER. His last deep vein thrombosis was over a year ago. He is on vacation and states that he is due for his INR check. He says that his PT is typically 16 to 18 seconds and his typical INR is 2.0 to 2.3. The ER doctor orders a PT and the results come back as 25.7 seconds, but the INR is 2.2. The patient is confused by this result and thinks that the lab has made a mistake. Well, do you think the lab has made a mistake? I don't know. What's the explanation for these results? And what are three major variables affecting stability of oral anticoagulation? Okay. See if you can find out more information about that INR, what it's for, what it does, and then the variables that can affect that. So we'll come back and discuss it. Take your time, do your best. Okay, we are back with case study 1-8. So we're looking at our 67-year-old man who's on long-term Coumadin therapy, and he's on vacation. Good for him. He says his PT is usually 16 to 18 seconds and his typical INR is 2.0 to 2.3. The doctor orders the PT and proceeds to read back his results as 25.7 seconds, which is markedly more elevated than the 16.8 that the patient is used to having. But you'll notice the INR is 2.2, which falls right into our patient's INR range. Patient is confused by his results and thinks that the lab has made a mistake. So the INR is a standardized measurement of the pro time, more or less. And the reason why we have the INRs is so patients can go pretty much anywhere, have their pro time drawn, and then have a standardized unit of measurement that accommodates or accounts for discrepancies or differences in reagents, instrumentations, methodologies between the labs. Because we really have to have a standard way of measuring warfarin use that is going to allow patients not to be, have to go to the same lab every time, and also a way to make sure that they are getting their monitoring done appropriately so that their dosages can be accurately prescribed. So the discrepancy is due to the different reagents and instrumentation between the labs. That's why there's a big difference between the pro time at his home lab and the pro time at his ER. And the INR is in the desired range. So this patient is stable. No dosage needs to be changed if this is the therapeutic range for the INR. So ultimately, the INR is going to be should be the same or should be valid between places. What are three major variables affecting the stability of oral anticoagulation? So, and we're talking specifically about medication that could be given for a multitude of reasons. It doesn't necessarily just have to be warfarin, but in this case, he was on Coumadin. There are three major variables. So the first one with regard to Coumadin would be vitamin K and the diet. So we need to make sure that we're not eating anything that's going to interact with our coagulation therapy. Medication interactions are also a big deal. So antacids and antibiotics could interfere, and especially with Coumadin, that's a problem. And then proper dosing and compliance. That means the patient needs to be taking their medication when prescribed in the amount that's prescribed and coming in to do their regular blood work to make sure that their dose is still accurate. The one good thing about Coumadin is that there is an antidote. It is a vitamin K shot. And so for lots and lots of people who are maybe elderly, a little forgetful, but still living independently, every once in a while we have one who accidentally takes too much Coumadin, thinking they've already taken their medication, and then they forgot that they'd already taken their medication. So again, they take it and now they've overdosed, and it's not great. So monitoring them closely is important, and also the fact that we have a vitamin K injection we could give to counteract it is comforting, to say the least. Here is our last case study for section 1. Case study 1-9, a 44-year-old woman with a known lupus anticoagulant experiences a deep vein thrombosis. The doctor wants to begin anticoagulation therapy. So let's take a look. We have a PT of 13.6, PTT of 84. What therapy should this patient receive and how should it be monitored? Okay. So she has a known lupus anticoagulant, and now she has a deep vein thrombosis. So remember, I told you that that non-specific inhibitor or that lupus anticoagulant presents with a prolongation of a PTT, but really it can cause thrombotic episodes. So let's see what we should do. We are back. Case study 1.9 or 1-9. It's a 44-year-old woman who is known to have a lupus anticoagulant, also known as an antiphospholipid antibody. These both fall under the category of non-specific inhibitors, and she now has a deep vein thrombosis. The doctor wants to begin anticoagulant therapy. So what therapy should this patient receive and how should it be monitored? Now, we haven't really gone into depth in terms of our test menu, and we will do that today or maybe tomorrow. So keep your eyes open for that. But our standard unfractionated heparin or our low molecular weight heparin is the preferred method for deep vein thrombosis. The reason why is um, heparin will help break down clots that are present and will prevent new ones from forming. Whereas some other types of anticoagulants like like Coumadin is more preventative and it won't necessarily break down clots, but it will prevent clotting. So there really has to be the proper medication for the proper situation. The way we monitor the use of heparin and heparin directly, we directly monitor it, is by the anti-10A assay. Now, you might be thinking, oh, but wait, I thought that heparin affected the intrinsic pathway. Yes, it does. But we can measure the anticoagulant effects with the PTT, but we can directly measure heparin itself with the anti-10A assay. So we're monitoring the drug with the anti-10A assay. We're monitoring the effects of that anticoagulant on the intrinsic pathway utilizing the PTT. Warfarin is measured by the PT-INR. Not so much, we don't necessarily have a direct warfarin measurement per se in our coag department anyway. So we do utilize the ProTime INR to make sure that the anticoagulation is at the therapeutic level that the doctor wants based on the patient's condition and history. So for example, a patient who is has a history of deep vein thrombosis, the therapeutic INR might be between 2.0 and 3, and a patient with a mechanical heart valve may have a higher INR because they want them to be a little bit more anticoagulated of 2.5 to 3.5. So there can be some variation based on the patient's condition and the need. So when we have ProTime INR results for our Coumadin clinic or our warfarin clinic, it's really just important for us to relay that information appropriately so that if for some reason it's not within a therapeutic range, that the patient is able to have a dosage adjustment so that they maintain the therapeutic state of anticoagulation. All right, so that is the last of our first set of case studies. Well done. I hope you were able to complete at least the majority of those on your own. If not, please ask me questions, send me emails, send me text messages. I'm really hoping the best for you all in your successful accomplishment of this course. So please don't hesitate to reach out. We are going to move on next to our coagulation disorders worksheet. Please finish that worksheet prior to the explanation and review in this presentation. Next up, we have our coagulation disorders worksheet. When working through this worksheet, use your coagulation disorder PowerPoint presentation as an aid to you. And please finish this before looking at the answers, okay? All right. Our coagulation disorders lecture worksheet, define the terms. Complete the following worksheet while viewing the coagulation disorders PowerPoint presentation and make your best efforts to complete this worksheet independently prior to looking at the answers. So I think that's pretty straightforward. Go ahead and define the following terms. I'll give you some time and then we will come back and talk about it. Hopefully you were able to complete this page. Let's go over them. Zymogen is an inactive precursor of the clotting factors. Hemarthrosis is a term we use for bleeding into the joints, which again we see in all of the hemophilias. So And we also see in factor 7 deficiency. So factor 7, 8, and 9, we see that pretty often. Menorrhagia is heavy and or prolonged menses. Epistaxis, nosebleeds. Ecchymosis, bruising. Um, factor 8C just means coagulant activity of factor 8 measured by the factor 8 assay. Von Willebrand factor Ag is basically means the von Willebrand factor antigen. That is going to be responsible for platelet adhesion to the endothelium. It's also responsible for helping to stabilize factor 8. Remember? Think of von Willebrand's antigen as the glue that helps platelets stick to the site of injury as they're forming their platelet plug. And then we've got von Willebrand factor activity. So the antigen is the glue, the activity is how sticky is the glue. And then we have the factor 8 and von Willebrand factor complex. It's a complex of factor 8 and von Willebrand responsible for anchoring the fibrin platelet plug to the site of injury, but also it helps to stabilize factor 8 from all of its wily liability problems. Don't you just love matching? Match the following terms. So on the left, we have the name of the factors, and to the right, we have the factor number. Go ahead and match those, and when you're all finished, meet me on the next slide and we'll talk about it. Okay, here are the answers we've got, and you should be able to answer these easily. I'm not even going to read them off to you, but if you would like to verify them, go ahead and take a look back at that coagulation disorders PowerPoint presentation. You will need to know these for your exam, for your boards, and for your final exam. So please make your best effort to memorize the different nomenclatures of our factors. Moving on to the next portion of that worksheet, answer the following questions. What are the two categories of impaired coagulation? Give 2 examples of each. So I'm looking for 2 categories and then break it down further. Number 2, what is the most abundant coagulation factor in the circulation of normal individuals? Number 3, which factors are considered labile? Number 4, what are the vitamin K dependent factors? Number 5, which vitamin K dependent factor does not respond to vitamin K therapy? And what factors are contained in the following forms of replacement therapy? So we've got cryoprecipitate, fresh frozen plasma, Novo-7 prothrombin complex. So it's in your best interest to do this worksheet because you will benefit greatly by utilizing it as a studied resource prior to your exam on secondary hemostasis and in general. All right, let's take a look at the first question. What are the 2 categories of impaired coagulation, and give 2 examples of each? So the 2 categories that I was looking for are quantitative is the first and qualitative is the second. So really 2 examples of a quantitative disorder or impaired coagulation cause would be number 1, a decreased synthesis of factors, so it could be a deficiency of a factor, or loss of factors due to consumption or hemorrhage. So those consumptive coagulopathies like DIC or massive blood loss can also cause you to lose coagulation factors. DIC, they become depleted because they're being utilized or consumed. And with massive blood loss, as you lose that blood, you are also losing all of the coagulation factors that were in circulation. Qualitative causes of impaired coagulation might be a synthesis or of dysfunctional proteins. So we might have a gene mutation that causes the shape of our proteins to come out not quite the way it should, and they can't bind with their cofactors or their substrates, and then they aren't able to perform their job appropriately. We might also have a qualitative disorder due to inappropriate inactivation of factors due to inhibitors or antibodies. So this is where we come into inhibitory practices or inhibitory problems with both specific and non-specific inhibitors. Okay, number 2, what is the most abundant coagulation factor in circulation in normal individuals? And that is fibrinogen. Which factors are considered labile factors? And that would be factors 5 and 8. What are the vitamin K dependent factors? We're going to have factor 2, factor 7, factor 9, and 10. And an easy way to remember that is 2 plus 7 equals 9, and then 10 follows. Which vitamin K dependent factor does not respond to vitamin K therapy? And that, of course, is factor 10. Factor 10 has a mind of its own. What factors are contained in the following forms of replacement therapy? Okay, so cryoprecipitate contains von Willebrand's factor, fibrinogen, factor 8, and factor 13. Fresh frozen plasma has all factors. And then Novo 7 is our factor 7 concentrate. The prothrombin complex have factors 2, 7, 9, and 10. Do you notice anything about that? Those are all of our vitamin K dependent as well. So if you look at that, it kind of gives you a clue. Moving on, answer the following questions. Number 7, what are the contact factors? What hereditary pattern is associated with hemophilia A and B? Hemarthrosis is commonly associated with deficiencies in which factors? Which factor deficiency is usually not associated with bleeding, and under what conditions does bleeding tend to occur? Which factor deficiency is associated with amyloidosis? Which factor deficiency is frequently seen in patients of Jewish descent? And the most common multiple factor deficiency involves blank and blank. Okay, do your best to answer those questions. I will see you on the next slide. Happy hunting. Answer the following questions. What are the contact factors? Well, those contact factors are the ones that we see in the initial activation of coagulation. So it's going to happen at the point of contact, so to speak. We're going to be looking at factor 11, factor 12, prekallikrein, which is sometimes called Fletcher, and then high molecular weight kininogen, which may also be called Fitzgerald or homework. What hereditary pattern is associated with hemophilia A and B? Well, typically these are sex-linked recessive. So that is why we have a higher prevalence in males than females. Those males inherit it from their mother on that X chromosome that they receive from her. Hemarthrosis is commonly associated with deficiencies of which factors? We might see factors 8, 9, and 7. So all of the 2 hemophilias and then factor 7. Which factor deficiency is usually not associated with bleeding? And under what conditions does bleeding occur? So most of those contact factors, with the exception of factor 11, they typically don't have bleeding issues unless that PTT is prolonged greater than 100 seconds. Now at that point, we definitely would have some concerns. Which factor deficiency is associated with amyloidosis? And again, that's factor 10. Which factor deficiency is frequently seen in patients of Jewish descent? That would be factor 11. And then the most common factor deficiency that comes in pairs involve factor 5 and factor 8. So far, how are you doing? Hopefully you're doing all right. Okay, answer the following questions. What factors are measured by the PT and the PTT? Definitive diagnosis of a factor deficiency is made by doing what test? Number 16, when performing a factor assay, 4 serial dilutions are commonly used and why? So actually this should be 4. This 4 should be 3. So if you want, you can cross that out. Let me see if I can do that. No, it's not going to let me do that. That's all right. Here, let me erase that and see if it. Okay, we do 3 serial dilutions. I'm sorry, that is a pretty sad looking little doodad there. Okay, why do we use those 3 serial dilutions? And what is the difference between a functional assay and an immunologic antigenic assay? What is each measuring? Number 18, in a patient with afibrinogenemia, what are the results of the PT and the PTT tests? Number 19, which factor deficiency is associated with a normal PT and PTT? And then number 20, which factor deficiencies are associated with a normal PT and a prolonged PTT? 21, which factor deficiencies are associated with a normal PTT and prolonged PT? We will find out. All right, do your best to answer these questions, utilize your resources, and we'll come back for an explanation on the next slide. Answer the following questions. Let's take a look at number 14. What factors are measured by the PT? Well, we know that factor 7 is measured by the PT because it is in the extrinsic pathway, but we also have the factors that are in the common pathway, the PTT or the PT measures those as well, so 10, 5, 2, and 1. The PTT measures pretty much everything else with the exception of factor 7 and factor 13. But it also includes the common factors or the common pathway factors. A definitive diagnosis of a factor deficiency is made by doing what? Okay, so let's say that we have a prolonged PTT and the doctor suspects a factor deficiency. We do a PTT mixing study, and indeed there is a correction that occurs when we add that pooled normal plasma. This would be indicative of a factor deficiency. But in order to determine or make a definitive diagnosis of a factor deficiency, we have to do a specific factor assay. So that factor assay that's showing us the activity of the specific factor that we're looking at is going to be the only way that we can definitively diagnose a factor deficiency. When performing a factor assay, 4 serial dilutions, and again that should be 3. Let me fix that. Okay, let me see. That is not my best 3 ever, but I apologize for that. So 3 serial dilutions are commonly used. Why? Well, it's to look for an inhibitor, specifically non-specific inhibitors, because those non-specific inhibitors will exhibit increased factor activity as the dilution increases as well. That's because those inhibitors will be diluted out, which then they can't inhibit the factors as well, and therefore the factors are allowed to or able to express their activity. Number 17, what is the difference between a functional assay and immunologic antigenic assay? And what is each measuring? Well, the immunologic antigenic assay is a quantitative test that is measuring the amount of this specific antigen. So we're looking to see, for example, how much of the antigen is present. So the factor, do we have enough of it? And then the functional assay is how well is that protein working? And it is qualitative, qualitative and measures the activity of the antigen. So one is measuring the amount, the other is measuring the function. In a patient with afibrinogenemia, what are the results of the PT and the PTT tests? Well, remember, patients with afibrinogenemia usually have no fibrinogen, which means they have no clotting available because there's no substrate. So they would have an infinitely prolonged PT and PTT. Number 19, which factor deficiency is associated with a normal PT and PTT? Well, there's really only one factor that we don't use the PT or the PTT to measure, and that is factor 13. Which factor deficiencies are associated with a normal PT and a prolonged PTT? Okay. So that would pretty much be all of the factors that we have that are measured under the PTT. So we might have factor 8, 9, 11, 12, PK, homework, but it would not include this time the factors in the common pathway because again, the PT also measures the common pathway. Which factor deficiencies are associated with a normal PTT and a prolonged PT? That would be a factor 7 deficiency. We are almost there. This is the last page of our questions. Answer the following questions. Which factor deficiencies are associated with a prolonged PTT and PT? The Stipend time will differentiate between which two factors? 24. How long does it take for Coumadin therapy to produce any noticeable results? Number 25. Once Coumadin is discontinued, how long does it take for the PT to return to normal? 26. Why can long-term antibiotic therapy prolong the PT and PTT results? 27. What are the two most common inhibitors seen in the clinical lab? And 28. Which type of inhibitors are time and temperature dependent? Okay. Take your time, do your best. We'll come back and talk about these questions in just a few minutes. All right, welcome back. Let's answer the following questions. Number 22. Which factor deficiencies are associated with a prolonged PT and PTT? The factors that are going to be prolonged in both the PT and the PTT will be the factors that are associated with the common pathway, and that will include factor 1, 2, 5, and 10. The Stipend time, number 23. A lot of people ask what is the Stipend time? Again, remember it is that Russell's viper venom that we use. Factor 10 does affect the reaction and factor 7 does not. And so remember, factor 7 comes down into from the extrinsic pathway into the common pathway, right where factor 10 is activated. And so sometimes it gets a little questionable about exactly which factor is causing the problem. But using that Stipend time can help us differentiate between factors 7 and 10. Number 24. How long does it take for Coumadin therapy to produce any noticeable results? Typically 1 to 2 days, but we oftentimes continue to anticoagulate with an overlap of heparin usage for 3 to 5 days until Coumadin therapy can be confirmed to have everything anticoagulated appropriately. And we're going to talk more about that when we get to our therapeutic drugs. Once Coumadin is discontinued, how long does it take for the PT to return to normal? And again, we discontinue Coumadin and give them a vitamin K dose, usually takes about 3 to 5 days for normal PT to resume. Why can long-term antibiotic therapy prolong PT and PTT results? Well, as you remember, antibiotics can reduce the normal flora associated with a healthy gut health. These normal gut flora produce vitamin K, and this is necessary to make vitamin K dependent factors. The reason why the PT and the PTT results are both prolonged is because we have vitamin K dependent factors in both the intrinsic and the extrinsic pathway. Now, I had one student ask me a really great question, so I'm going to repeat it here. They said, why, if we have vitamin K dependent factors in both the pathways, do we only use the PT to measure warfarin? Because warfarin has an effect on vitamin K production. And the answer to that is, if you remember back, vitamin K is necessary to produce all of those factors, but with warfarin, usually we utilize it to regulate specifically factor 7. Remember, factor 7 has the shortest half-life of all of the other factors, specifically all of the other vitamin K dependent factors, and therefore we can knock factor 7 down before the others are affected. And so that's why Coumadin therapy also requires a really significant amount of monitoring. And then the PTT intrinsic pathway factors that are vitamin K dependent are not as significantly impacted, and that's just because of that extra short half-life that factor 7 has. What are the two most common inhibitors seen in the clinical lab? Factor 8 and 9 inhibitors, but factor 8 is more common than factor 9, and that lupus anticoagulant. So one is going to be a factor-specific inhibitor, which is factor 8 inhibitor, and then the other is a non-specific inhibitor, that lupus anticoagulant. Sometimes you'll hear it called a phospholipid antibody. And those are the two most common inhibitors seen in the clinical lab. Which type of inhibitors are time and temperature dependent? Those would be the factor 8 and factor 9 specific factor inhibitors. And the reason why they require time and temperature is that it allows them to actually inhibit the factors. If we add them and there's an inhibition going on, say for example, a patient who has a specific factor inhibitor, and we want to do a mixing study and we add that normal pool plasma and then we test it right away, well, the inhibitor hasn't had a chance to inhibit the factors that it acts upon. And so we have to incubate it for a while and then test it after it's been warmed and incubated to give those specific factor inhibitors time to act upon the factors that they are specific to. I hope that makes sense. Thank you for working so diligently on these questions. They are going to be very helpful to you. If you have any questions, again, please reach out to me. And I will be doing some more lecture and posting more regarding our APTT differential mixing studies, mixing study explanation for both the PTT mixing study, the PT mixing study, before we get into our therapeutic anticoagulant portion. Have a great day. Study hard.